Right, good evening, everyone. We'll make a start. Thank you so much for taking the time to join me this evening for one of the first of our webinars, Video Consultations, Doing It Well. My name is Dr. Catherine Glass. I'm one of the directors of the clinical workforce at Dr. Care Anywhere. I'm also an NHS GP and an NHS England appraiser. Right, so why are we doing this webinar and why do we feel we can guide you on video consultations? So it probably helped to tell you a little bit about Dr. Care Anywhere. We are a doctor-founded organisation that's been delivering remote consultations for the past 6 years. In that time, we have provided over 100,000 remote GP consultations. We only deliver consultations currently to the private sector, largely looking after corporate patients and their families. But in this time frame, we have built up our own platform and have learned a lot how to provide safe, high quality and effective patient care. We have around 100 GPs working for us, all of whom also work in the NHS. And in the wake of these really challenging times, given the COVID-19 pandemic, the clinical team wanted to put together a training programme to assist our NHS colleagues delivering healthcare on the front line. So just to go through the agenda for this evening's webinar, we're going to talk a little bit why us GPs fear doing video consultations. Hopefully going to talk through the practicalities of providing video consultations. Some considerations for triage, if you consider triaging appointments that come through into your surgery, whether it be for phone or video, and some expectation setting that you can do at triage alongside defining any limitations on what you are willing and less willing to do over video. We'll also be talking through some potential considerations for your surgeries and going through some questions and answers. So some thoughts, why I don't want to do video consultations. So why are GPs a bit resistant to do video consultations? So in fairness, they may say, no one's ever trained me. How can it be safe if I can't examine the patient? That's a commonly occurring query. I'll be prescribing antibiotics like Smarties. It's not an efficient use of my time. What about things like governance and GDPR? So all reasonable concerns from the clinical workforce. But more to the point, why should you be doing video consultations? Well, firstly, I hope after this webinar you'll agree video consulting is really straightforward. You can examine a patient through video. The convenience factor leads to much higher patient satisfaction. It also eliminates the cross-infection risk, which is unbelievably important at this time. And staff get to work from home, which is an absolute novelty for us GPs, or at least some of our GPs. And who do we feel is best placed to be delivering video consultations? Well, it's local GPs. So you guys know your patients best. You have access to the full patient medical records. You know about and can navigate your local services well. And in these testing times, our patients, they want to be speaking to us. So whether it's to reassure them that they do or don't have the coronavirus. And aside from the coronavirus, as we know, we've got a rising mental health burden. There are, of course, ongoing chronic and acute health needs that we need to serve in our populations. And of course, those queries about anything that may potentially affect life expectancy, around potential new cancer symptoms and so on. So now I'm going to hopefully talk through with you how to put video consultations into practice. So I'll talk through a professional setup. I'll give you a kind of semi-scripted introduction that we feel has worked really well, the importance of a thorough history, the importance of red flags, how you can be creative when you are consulting with your patients, particularly around examinations, the importance of sharing management plans out loud with the patient, and also the importance of safety netting and specifically defining your follow-up criteria. And I hasten to add, I know you're all going to be really good GPs. You're going to know how to do a lot of this anyway, so I really don't want you to feel like we're teaching you how to suck eggs here. We just hope that this information is going to prove helpful and improve your confidence in doing video consultations. So, professional setup. So whether you're at home or at work, make sure you're sat at a comfortable desk in a private, quiet and confidential area. Ideally with a plain background, so no lovely distracting artwork, and no sort of household, less attractive household clutter visible. Closed doors if they're visible behind the camera, and also avoid having windows in the background because that can create a bit of a glare when you're consulting. And do be aware of lighting. It's often more effective if you're facing a window or you have a bit of a lamp on your desk or near to where you're consulting. Positioning and body language. So be really mindful of your positioning when consulting via video, using either a phone or webcam. Be framed in the middle of the screen with the whole of your face and the top of your shoulders visible to the patient. So as I am sat now, do try to make good eye contact and be very mindful of your body language. When we're consulting over the phone, we can, dare I say, roll our eyes or, scrunch our head if the patient is going on. You just can't get away with doing that when you're consulting via video. Of course, I never roll my eyes when I'm speaking to my patients, but just to be very more acutely aware of your eye contact and body language. And you have to kind of avoid overusing normal verbal cues when you're doing video consultations, because there can be a slight time delay and you can end up just slightly interrupting the patient as they're trying to tell you their symptoms. So starting the consultation, it's really important to start the consultation well, to sort of set the rapport, right from the start. And we've put together a sort of a semi-script for the consultation. So when I consult remotely, an example of how I start the consultation is, hello, my name is Dr. Catherine Glass. I'm one of the GPs calling from the surgery. Before we get started, please could you confirm your full name, date of birth, and current location. Now note here we put current location, not registered home address. The reason being this is a CQC requirement. So if the patient were to become very unwell on the other end of the video consultation, then you need to know where the patient is located to get the ambulance out to them. So asking them to just verify their current location is definitely recommended. And taking a history. So you will all know how to take a good history, but when you do consult over video, you have to take a thorough history, and dare I say, assume the worst, so you can only so that you can reassure yourself. And of course, that links into checking any red flags associated with the presentation. And if the diagnosis is unclear, which of course it can be, I tend to then just go through a systems review and I talk out loud with the patient that I'm just going to ask about other parts of the body just to try and figure out what's going on. So we're confident that you can video consulting isn't about just communicating with the patient. You can definitely use it as an assessment tool. And it's really important to document any examination findings you note on video, including any negatives. And we're confident that the following areas can be examined well via video. So things like general appearance, musculoskeletal symptoms, abdominal symptoms, and so on. So I'm going to talk through each of these systems now with you. So you've got your good history. You're now thinking, I probably know what the diagnosis is. I'm just going to see whether this ties in with the examination findings. So general appearance, what's the colour of the patient? Do they look well perfused? How alert are they? Are they in pain or are they comfortable at rest? And how is their mood? So how is their eye contact? Are they very tearful? What's their speech tone like? How's their body posture? How's their behaviour? I would say that's more relevant in children, and we'll talk a little bit about examining children a little bit later on. Respiratory examinations, so if someone's presenting with a cough and or shortness of breath, very relevant at the moment. You can just check for breathlessness. Are they talking in full sentences? Are they really using their accessory muscles when they breathe? Do you notice any kind of tracheal tug? What's their cough like? Ask them to cough for you. Is the chest pain pleuritic in nature? So ask them, take a deep breath in for me, madam. Do you get a pain at the end of your breath? If you are concerned about a P, you can ask them about calf swelling, and if you're unsure, you could ask them to show you their calf on video. And you can also check for things like cyanosis. We would hope that cyanotic patients aren't using video consultations to consult with you, but that's also what you can check for. So common diagnoses with our service are ERTs, lower respiratory tract infections, asthma, whooping cough, and croup. So we've confidently diagnosed all of these via video without examining the patient. The reason I put the lower respiratory tract infection in brackets is because my personal feeling is I would like my patient to have their chest listen to if there is a query that there's a pneumonia going on. Current circumstances of a reduction in in-person NHS appointments being available means we have to really hone in on the history and really safety net, and then perhaps consider slightly altering our risk-benefit profile and consider giving oral antibiotics for a lower respiratory tract infection over a video consultation. Skin examination, I will say at this point that the photos are definitely preferable to video. You definitely get a better resolution. But ask the patient to describe their rash. Rashes, as we know, tend to be either atopic, infective, or something other and a bit more random, like an autoimmune condition and so on. If there is a concern that it sounds slightly dangerous, there are any red flags, do ask the parent or guardian to do the glass test with you over the video consultation. And again, common diagnoses that we see and confidently manage via video are eczema, psoriasis, scalp dermatitis, fungal skin infections, shingles, and gout. Musculoskeletal examination, so you would, asking the patient to look at the joint would be very reasonable. Is it swollen? Is it bruised? Is it red? You can do a lot of range of movement stuff with joints, and of course pain on certain movements. So the classic is, the painful arc with rotator cuff injury. And again, common diagnoses we've seen with our service: rotator cuff injuries, ankle sprain, olecranon bursitis, muscular lower back pain, costochondritis. So common general practice musculoskeletal presentations. Abdominal examination, so you're seeing a patient, they're complaining of abdominal pain. What do you do with them? Well, you guide them through a bit of a self-examination. So ask them to point to where it's tender. Are they comfortable at rest? When they put their hand on their tummy, how tender is it? Is it soft? Is it hard? Ask them to suck their tummy in, push it out, cough. Are any of those maneuvers painful for them? Are they able to walk comfortably with abdominal pain? If a child, can they jump up and down with their abdominal pain, just to put a level of severity on it? And then if you're feeling bold enough, and or if you think that it will add to your examination, feel free to ask to examine the abdomen. I'm not sure how I would feel showing my gut to my doctor, but equally it can be helpful just to inspect for any rashes. Is this a shingles referred pain, any fluid overload, or any obvious jaundice? So common diagnoses we've seen again on the platform: GORD, constipation, irritable bowel, UTIs, hernias, ovarian cyst, and appendicitis. Only seen one appendicitis, certainly didn't manage them over the video, signposted them on to A&E, but it can happen. So in nose and throat examinations, again, do a bit of self-guided examination with the patients to get them to use their phone light or something similar, or another kind of torch. Tell them to go off to their nearest mirror and have a look at the back of their throat. Is there any exudate there? Thinking of centre 4 criteria. Do they have swollen glands? Do they have a tender tragus, which is seen in otitis externa? Is there any swelling or tenderness behind the ear? If you're really concerned that they seem to be very unwell, is there potentially a mastoiditis developing? So common diagnoses with ear, nose and throat that we see: tonsillitis, otitis externa, sinusitis, hay fever. We've definitely seen a few cases of mumps, and a classic nasal sores that respond beautifully to topical Bactroban. We're nearly there, but just hopefully you're getting the message that you can examine a lot over video. So just thinking of the neurological and eye systems. So you can, of course, inspect the eyes. You can do the range of movement on the eyes. You can do a modified cranial nerve examination. The patient may think you're winding them up, but you can obviously go through the raising of the eyebrows, the scrunching of the eyes, the blowing out of the cheeks, clenching the teeth, sticking out the tongue. Ask the patient to feel their own face. Are they more numb on one side? How is their facial nerve? Shrugging and holding the shoulders. And also just checking for hearing. So I do a gross test. Just ask the patient just to rub their fingers together, essentially, just to create a rub to see if they can hear that or not. And then finally, scalp tenderness, a classic with temporal arteritis. So again, what are the common stuff we've seen on the platform? Styes, see them an awful lot. Conjunctivitis, blepharitis, dry eyes, tension headaches, and migraines. We're nearly there in examining, so well done everyone. Examining children, so we do see children on our service. Picking up on their behaviour is really key, as it is when you're consulting with children in practice. So If they're happy, smiley, bouncy, that's going to really reassure you. If they're irritable and drowsy, then you're really going to lower your threshold for whether you need to get them examined or not in person. How's their colour? Be very mindful of safeguarding issues. So just be making sure you're checking on the interactions with the parent or guardian, any signs or symptoms of neglect. And as I've said before, we definitely lower thresholds for in-person examinations. So if we're not sure, we will be signposting the parent on to either come into the surgery for an examination or to attend a local walk-in centre or A&E. And common diagnoses, we can treat patients, our children rather, virtually over videos. We've definitely treated nappy rash very effectively, given very practical advice on ERTs, gastroenteritis, constipation, eczemas and dermatitis. So some final examination tips. You'd be amazed at what observations you can get from video consultations. So, feel free to ask the patient to check their radial pulse. You can certainly do this in older children and adults. And if you time 15 seconds for them, and just ask them to tell you what their pulse was in that time. And do check home equipment. As you know, our patients are definitely far better equipped than they used to be. So they'll often have a thermometer, a blood pressure machine, perhaps a Fitbit, other jazzy apps. They may even be super keen and have SATS probes and urinalysis sticks. So just worth asking them. As an absolute must not, never examine intimate areas over video. Hopefully that goes without saying, just in case there's any kind of miscommunication. Videos, consultations won't be recorded at your NHS surgery. So if there's any concern or any need for an intimate examination, bring them into the surgery. And just always be mindful of safeguarding issues when you are consulting via video. Are they staying away a little bit more because they're trying to hide something? So always just have that in the back of your mind. So what have we learned at Dr. Care Anywhere, having done over 100,000 consultations, at least half of which have been video? I think we've learned essentially that there is so much that you can do over video. And I hope that I've slightly reassured you that you can safely diagnose and effectively manage your patients over video. Interestingly, we've had a large amount of patients with mental health problems, particularly in men. So it seems that they are more likely to book an appointment if it is easy to book it, and or if there's that slight anonymity to the consultation, or dare I say the more remote element to the consultation. I can't tell you how much our patients and our doctors love it. So we're currently running at about 4.8 out of 5 for patient satisfaction in the medical advice that they get when they consult with us over video. But what I will say is time is needed. We're very lucky to be able to give our doctors and patients 20 minutes to consult. I'm not suggesting you do that. I know how busy NHS surgeries are. But I certainly wouldn't recommend going below 10 minutes because of the reasons I've demonstrated. You have to be able to have the time to do a thorough history and or do a bit of examining and keep accurate medical records. So do just be aware that a bit of time is needed to conduct these consultations. Triage can play a really good role in video consulting. So Dr. Care Anywhere, all our consultations undergo triage. So we know exactly the kind of stuff that's coming in before we end up doing the video consultation with the patient. And we also can pick up on those things that absolutely are not appropriate. So we do not see at Dr. Care Anywhere patients with, for example, central crushing chest pain. It is just not appropriate for them to have waited to come through to a video consultation to be told that. So we sort of scoop those kind of cases up at triage. And also, we've just got to accept that some conditions are not suitable for video consulting. So as I mentioned, if an intimate examination is required, that's not suitable. If certain new medications need to be started, again, that's not suitable doing that over video. If triage does happen, it allows you to really optimize the video consultation by sending or asking the patient to do certain things before the appointment. So if you see the reason why your patient has booked in a video consultation, for example, they want a repeat of their contraceptive, a new note on the system, they haven't done a blood pressure or their weight for a long time, you could just message them saying, look, any chance of getting a blood pressure from your local pharmacy and checking your weight before I speak to you. Likewise with rashes, if you can get them to email in a picture before the consultation over video, great. And of course, you know, the classic female fertile woman with abdominal pain, it would be lovely to be speaking with her over video, knowing that she's done a negative pregnancy test. So what does DCA do, and what could your surgery do? So as I think I've alluded to them already, but just a bit of expectation setting, online booking, if you do end up doing any kind of triage. In surgery, you could consider using your receptionist to play a key role in the expectation setting. As I mentioned, triage can be really, really helpful and effective, and just make sure the right people are coming through to have video consultations. And you could consider, you know, ways of triaging at your practice and enabling your clinical staff to support GPs before they end up doing the video consultations. And sharing any messaging at triage can be really helpful, as I've mentioned, to optimize the video consultations. So it may be helpful for you to be verbally or digitally communicating with the patient prior to the call, or explaining that it's not appropriate for video consultation for whatever reason. And then just think about ways of we have done automated technology solutions, which basically ensure that when the patient comes through to do the video consultation, they've checked their equipment, so their microphone works, their webcam works, etc. So it's worth thinking about ways you can automate this prior to the video consultation starting. So whether you could just send a text to every patient who's about to have a video consultation that they need to, I don't know, join this link or something like that. So this pandemic will pass, and one positive is that it is forcing us to consider providing healthcare in different ways, but this will be of longer term benefit in maintaining patient satisfaction, but perhaps more importantly in providing sustainable working patterns for our clinical workforce. So a better patient experience leads to a better consultation, which leads to improved job satisfaction. You could end up running, trust me, quieter, organised, more efficient surgeries. You could think about, if you have having to use locums, smarter locum use. Instead of scheduling by the sort of half day, you could think about scheduling per hour. And it's really flexible work for you and your staff doing video consultations. Well done, guys, we're almost there. So just to finally mention how we can support you after today. So we are putting together training material and e-learning packages with supporting information. We're hoping to run virtual drop-in clinics to answer any specific individual questions. And we're looking also to support surgeries in making them more digital and providing support and guidance to your non-clinicians and other healthcare professionals. Brilliant. So there we are. I'd be really interested if you guys have any questions. I hope you found that helpful. If I could just ask that you use the Q&A section on Zoom. So if you, instead of the chat section, that would be really helpful, and we can go through them. The alternative is I let you all talk and then we could have a chat. How lovely would that be? Just bear with me. So you're all permitted to talk from the looks of things. So if you guys want to unmute, if anyone's got anything they want to ask or say, feel free to talk.
Hi. Oh, hi, Catherine. This is Anshu here.
Hi, Anshu.
In North London. Great summary, by the way. So I just wanted to ask a couple of things. Abdominal pain, I mean, how far can you really take that? And I think that's, you know, I've probably brought on everything you've talked about there. I always worry about abdominal pain, and I think that's the one where, from a sort of medico-legal, probably being a slightly risk-averse clinician, I'm probably slightly more concerned about that, which is, you know, at what point do we, how much can we really reassure ourselves if we've not put our hand on somebody's tummy? Because I think, you know, there's been plenty of time where, and I think very simple things like GORD, the symptomologies may be slightly different, you know, but Yeah, so really abdo pain is kind of probably my first question. And then
Yeah.
second question is, are there any overall don'ts and definitely don't do this or definitely don't do that, or any sort of major pitfalls?
Sure. So, yeah, it's a really good point. I definitely share your concerns around abdominal pain, but I think it's just falling back on the bread and butter general practice of using time as a diagnostic tool. And I think if you think about how many times you have examined tummies, they haven't demonstrated much, and then you've got caught out by a positive ultrasound scan or a CT and what have you. So I think we've just got to bear in mind that common stuff is common, and just be happy that there's nothing. So we've got to be happy that firstly, it's not an acute abdomen, in which case that would hopefully be pretty barn door. And secondly, there aren't those red flags that would worry us, weight loss, family history, night sweats, the sort of, blood in the stool, dare I say. And I think just falling back on the time being a diagnostic tool, that these symptoms should go away. And if they don't, you are going to need to come in so I can examine you. You don't wrap everything up by simply doing video consultation. That's the end of the patient journey. But all being well, all those, dare I say, worried well or minor ailment patients won't end up clogging your surgery in the same way.
Yeah, and I think documentation clearly becomes a paramount piece of here in terms of, especially around the safety netting, I suppose.
Totally. Yeah. And it does take time, and that's why I sort of alluded to this idea. You do need a bit of time to be doing these consultations, which I know the NHS isn't very good at facilitating, but yeah. In terms of absolute no-nos, I mean, our service, for example, we never prescribe benzos, we never prescribe any opiates over 50 mg of codeine. We're very mindful of starting medications which require therapeutic monitoring in some way, the methotrexates, the azathioprines. So I'm saying it, I'm sure you'll probably think to yourself, well, that's obvious, but having a very clear prescribing protocol is definitely recommended. And, just erring on the side of caution, if you're not sure, just don't be too gun-ho, just always listen to your clinical gut. And if you're not sure, you end up bringing the patient in. But and the absolute no-nos, as I mentioned, is just anything that could be misconstrued. So no, I've had men drop their pants when I'm talking to them, and I've still had to say, no, please, this isn't appropriate. You will need to go and see so-and-so. So yeah, I hope that helps.
Okay. One last thing, sorry, before I shut up, I'm sure you've got many other questions pending, is how would, obviously we have, 14 doctors across our 3 surgery sites. How do I go about getting what you've just told us to them? Because it's trying to herd doctors to one place is nothing short of a nightmare, quite frankly.
Yeah, absolutely. Where are you in North London?
In Southgate, Palmer's Green. Okay,
great. So we are going to share, we're going to share this presentation, all being well, that's the plan. You need to, I was a GP partner. I think, how would I approach it? I would probably set up a clinical meeting for the whole practice cross-site, and all being well, get people in-house. But if not, you could do a Zoom meeting virtually and go through this, and just hopefully just get your staff to understand the benefits which are around flexible working, having a bit more control, dare I say, being able to work from home, and just, it should, and hopefully this will serve to improve their confidence, but you can further add to improving that confidence by just being very clear in what you're expecting your staff to do, but also what not to do, so that you're all aligned. Consistency in general practice can often vary, as I'm sure you'll agree, from practitioner to practitioner, and making that a bit tighter can make practitioners feel a bit more secure in what they're doing.
No, agreed. Thank you.
Pleasure.
Hi,
Anyone
Catherine.
else?
Hello, Catherine.
Hi there. Hi, Neil.
Neil, yeah, I'm a GP in Essex. A really simple, silly question, really, but how would you exclude an otitis media when you can't look in the ear, relative to, say, an otitis externa? Yes. And the treatments are slightly different.
They are.
If you want to treat otitis media at all, of course.
Absolutely. So my feeling with otitis media is I will sort of say, look, this is either, there's a high likelihood this is viral, or I will ask about that classic, you know, the tympanic membrane perforation history. You know, how severe is the pain? Has it got to the point? And then slightly given, what's the discharge like? How much of it is there? But I rarely tend to prescribe oral antibiotics with otitis media anyway. But I would be very reluctant to be putting sprays and drops in if I was concerned. So I'd probably fall back more on conservative management, talking through that NICE guidance isn't to be prescribing oral antibiotics. And again, just falling back on time being the diagnostic tool, optimizing pain relief, and seeing how the next 3 to 5 days fare for the patient. And I would probably say to the patient, look, if it worsens and or you start to feel systemically unwell, we do need to be looking in your ear. But if not, let's just see how the next few days go.
Indeed. Thank you.
Pleasure. Any more for any more? If not, I can let you go and enjoy the rest of your evening.
Well, one more, Catherine. It's Neil again.
Yeah.
Fundal examination. It's obviously impossible to look in someone's fundi, but I suppose if you're getting to that stage, you probably would suggest that they seek either their own GP or, dare I say, going to casualty if it's that acute, if you suspect something more severe, if they've got a headache or whatever.
Yeah, so if you are, so you track it back, so you think to yourself, right, okay, I would want to look in the eyes to check for papilledema. I can't do that, so I'm therefore going to fall back on those history questions, and I'm going to think about any space-occupying lesion questions. So, are you woken up in the morning with headaches, any dizziness or balance disturbance, and so on. So you'd fall back on the history. And you're right, and if you think to yourself, gosh, these fundi need to be looked at. Likewise, if there's any malignant hypertension concerns, again, you want to look in the back of the eye, you can't, you just need to be falling back on getting someone to look in the back of the eye. But a lot of the time, with neurology presentations or headaches type presentations, I personally haven't felt the need to look in the fundi because I've been reassured by the history, but of course, just provide that level of safety netting.
Indeed, thank you.
Pleasure.
Catherine, I'm a colleague of Neil's. Just for one very quick question. You said that NHS consultations aren't recorded. So are you saying it's just the contemporaneous notes that are written into the patient record afterwards that go along? Because there is talk about that all consultations have to be recorded for a certain length of time. Is that not the case?
It's not. So, hello, is it Suman?
No, Pauline.
Pauline, apologies, Pauline.
That's
hello,
all right.
Pauline.
I'm on the same line as Neil, so that's what's.
Oh, lovely. Oh, that's hello, Pauline. Interestingly, NHSX put out some guidance today, or well, dare I say this week, essentially saying that they are relaxing their regulations around how NHS GP surgeries provide consultations, and that you as surgeries are able to use, you know, the standard video conferencing apps that are out there. So I don't know whether any of you guys have Accurix, so they have facilitated, that's a text messaging service for patients. They've added in a video consulting a function, but also things like Zoom, WhatsApp, etc. So I think NHSX are happy that they're encrypted enough to use, they're safe, but equally there absolutely isn't the need to be recording them. We personally have chosen to record our consultations so we can do quality assurance and give feedback to our GPs, but it's absolutely not necessary. You can fall back on the notes.
Yeah, AccuRx is amazing, I've got to say.
Yeah, and it's great what they've done, what they've managed to turn out in such a short space of time.
100%.
I just wish I thought of the idea.
And the patient, when they want access to their records, they will just get what they would get from a face-to-face consultation, irrespective of the mode of consultation, yes? Okay,
Exactly.
Thank you.
Pleasure. Any more for any more?
No, I think I'm done. Thank you.
No, pleasure. Really, thank you so much for joining me this evening. Enjoy the rest of your evening. And
Thank you,
Catherine.
if you are interested, absolute pleasure. If you are interested in any of our specific material, feel free just to email training@drcareanywhere.com and we'll just forward it on to you.
Thank you.
Is
It's
there,
been very
is
insightful.
is there any way, Catherine, we can get that email to us since we're on the call, or just in terms of, or do I need to email, do you think?
I'll certainly ask, but I'm so sorry to say, just so that we back it up, you'll definitely get it that way. But I'll certainly ask our marketing director if we can just get any attendees automatically sent the training material.
Oh, that would be great. Yeah, perfect. Thank you.
Absolute pleasure.
Have a good
Take
evening.
care,
Thanks.
good luck, and thank you for your hard work on the front line. Really, really appreciate it.
Thank you.
Thank you.
Take care. Bye-bye.
Bye.
Bye.